Hello and welcome to Pulse Check with Archer Nursing, where nursing comes to life. In this podcast, you give us 15 minutes of your day, and we'll take one complicated nursing topic and make it easy. Ready for nursing to be fun? I'm Morgan, and today we're actually tackling two topics, both dementia and delirium, and the differences between the two. So, as always, let's jump in with a quick practice question to get things started. As a reminder, say what you think the correct answer is till the end, and we will circle back to it. We have an 82-year-old client with moderate Alzheimer's disease that is usually calm, recognizes staff, ambulates with a walker, and a one-person assist. Tonight, she is disoriented, pulling out her IV and shouting about men in my room. She's drifting between agitation and drowsiness. Which nursing assessment finding best supports delirium rather than a progression of dementia? We have a gradual decline in short-term memory over the last 2 years. B, a fluctuating level of consciousness and inattention during the shift. C, difficulty recalling the names of her grandchildren. Or D, progressive problems with word finding and organizing thoughts. So think about it and let's dive into the why behind both delirium and dementia. We'll start with the brain itself and what's really going on under the surface there. So, your brain is basically, I want to say, like mission control for your consciousness, your attention, your memory. It is coordinating all of those. And there are kind of three big players that really matter for today's discussion on delirium and dementia. The cerebral cortex, which is going to handle our thinking, memory, planning. The hippocampus, which is kind of like the brain's, like, I'm going to say, save button for new memories. We're kind of saving on that short-term memory. And then the reticular activating system, that's in the brainstem. And basically that helps you stay awake, alert, and able to pay attention. Now, delirium and dementia are both going to change how the brain works 100%, but they do it in totally different ways and on very different timelines. That's going to be important for us as nurses deciding what's going on. You can think first of dementia as like a slow crumbling of a building over years and years versus delirium, boom, we have a sudden electrical storm and it just temporarily takes the building down. So let's start first with dementia, that slow crumbling over years. Especially in Alzheimer's, there is a progressive structural damage to the brain. Our neurons actually die. In Alzheimer's, we have abnormal proteins like beta amyloid plaques and tau tangles that build up in the brain, and especially in those first two areas we mentioned, the hippocampus and the cortex. Basically, those neurons are gradually going to lose their ability to communicate and then they degenerate, they die. So over time, the brain is shrinking. Hear me say that again. The brain is literally getting smaller with dementia because those neurons are dying. And that's why it is slow, it is chronic, it is irreversible. Once they're gone, they're gone. A key word that you might see on the NCLEX when it comes to talking about dementia is going to be the word progressive. The person is gradually losing memory, language, executive function. It is progressing, maybe not day by day, maybe not even week by week, but every month, every year, etc. They can tell you what they did years ago, but not what they ate for breakfast. Their personality slowly shifts. They get withdrawn or irritable, and over time, steadily, they start to lose independence. So now let's look at that third part, that reticular activating system. Remember, that's the part of the brain that helps keep you awake, alert, and able to pay attention. It usually stays mostly intact until those much later stages. So clients are generally awake, their level of consciousness is stable, and they can maintain attention early on in dementia. It's those higher level functions that go first: memory, judgment, problem solving, etc. So the lights are on, but the files in the cabinet are just slowly starting to disappear as those neurons degenerate. All right, let's shift gears and think about delirium. So what we just talked about, dementia, the building is slowly crumbling. Now delirium is that electrical storm. It is an acute, sudden problem with how the brain is functioning. Usually it's triggered by something else going wrong in the body. It's not this like slow structural damage over the years, like we saw with dementia. It is like the brain's chemistry going haywire over hours to days. Days, a little bit more rare. Really, this happens super fast. We think of it as like a global brain dysfunction. We have neurotransmitter imbalances, inflammation, impaired oxygen delivery, and changes in how the brain uses glucose and processes information. So we have a lot of things happening at once. Clearly, this is a very big deal. The first thing is that acetylcholine, which is crucial for attention and memory, drops off. Secondly, dopamine spikes. And then third, we get inflammation. This could be from infection, surgery, illness. I mean, so many things can cause inflammation, but it alters how our neurons communicate and essentially means that the brain eventually isn't getting enough oxygen. Maybe our sodium, calcium, or glucose levels are off, and these things stop the neurons from firing normally. Last but not least, that third system, the reticular activating system, is going to get dragged into all the chaos. So, level of consciousness and attention, they're out the door. A big difference I want to call out here with the reticular activating system getting dragged into delirium, level of consciousness and attention are the first things that go. So, if their level of consciousness changes dramatically really fast, I want you thinking delirium. Remember that the reticular activating system in dementia was the last thing to go. So the lights were still on, but the cabinets were slowly being emptied out. Their executive functioning and personality was slowly shifting. Things like level of consciousness are going to be the last to go. So that is opposite when we are comparing dementia to delirium. And that's the key contrast I want you guys thinking about. Dementia, chronic, gradual. We have a clear baseline, slowly starts to decline. Delirium, sudden and acute. We have inattention, we have altered consciousness. In dementia, the brain is slowly breaking down. In delirium, we have like a lightning fast, temporary glitching because something else is wrong. Now, it gets tricky because these absolutely can coexist. We can have a client with dementia who then acutely experiences delirium. And that's kind of what I'm wanting to talk about in this episode. That's the clinical scenario I'm about to go through here, because you're going to get NCLEX questions where clients have multiple comorbidities, multiple things going on, and you're going to have to kind of suss out what is happening. So the story I want to tell you today is a personal story about a family member. So I was at the bedside watching this play out, and I'm just going to call this client Mr. H, all right? He was, I want to say 78 or 79 years old at the time, and he was admitted to the hospital for pneumonia. He had a known history of dementia, but I would describe this family member as like pleasantly confused. That he needed reminders about where he was. We had to repeat things oftentimes when we would like yell across the house to get his attention. It took him a little longer to process things, but he was always calm, cooperative. He followed simple commands. He knew me. He knew my name. He could recognize his daughter. He could tell you that, hey, I'm in the hospital because I have a bug in my lungs. Like, he knew what was going on. Okay. So early stage dementia, pleasantly confused. All right, so he gets pneumonia. He's in the hospital. I go to visit. This family member only lived a few hours away from me. He had been admitted, I believe, for 3 days at this point. So not super long. And I walk in around dinner time. I believe shift change had either had or was just about to happen. But the night shift nurse was getting ready. And I knew something was wrong when I walked in. He was sitting up in bed, his eyes were wide. He was looking like past me into the corner of his room. And when I, like shook him, said, "Hey, it's me," like what? He didn't look at me. Instead, he was looking into the corner and he said, "Do you see them? Can you see those kids?" And I I mean, my heart dropped. I panicked a little bit. I was like, oh my gosh, he's having hallucinations. He's seeing something that I definitely cannot see. So I grabbed his nurse immediately. And again, yes, I think this was during handoff because the day shift nurse was still there. And she says, he's been like this all day. Excuse me? He's been having hallucinations all day and no one has said anything? This is a sudden change, all right? He was still oriented to person. He was able to have a conversation, but there had not been hallucinations documented until that shift. So this was a huge change. And I made sure to very clearly articulate that to the oncoming night shift nurse who took this very seriously, thankfully. And she was like, okay, let me finish getting reports and this I'll assess him first. He'll be my first patient that I'm going to go into the room. So I sit with him. He's still like very focused on what he sees in the corner. Next nurse comes in and he really gets quite agitated. And this was very disconcerting as a family member. I had certainly never seen him act like this, but he was trying to climb out of bed, saying, I've got to go catch the train. That would shift then 10 minutes later to where he was super drowsy. He could like barely keep his eyes open and was answering questions with just, mumbles. So like this up and down level of consciousness was a really clear indicator to me that this wasn't just a progression of his dementia. This was not baseline. He had new sudden onset neurosymptoms and a waxing and waning level of consciousness. So that really made me think that we might have delirium going on top of his dementia. Now, I do think it's important to say that a brain suffering from dementia is a vulnerable brain to delirium. And on top of it, this family member had pneumonia, so his body was inflamed. His oxygenation was certainly not perfect. He was on new medications, including an antibiotic for that pneumonia and opioids for pain. He had also been given a benzodiazepine in the emergency department, which was just a recipe for chaos in the brain. We really cooked up this delirium situation. He had infection, he was at risk for hypoxia, polypharmacy, and baseline, he had cognitive impairment from the dementia. So all of his brain's chemistry and oxygen delivery were out of whack, out of balance. His neurons were misfiring. This is the electrical storm that is delirium. And it's really important that the nurse recognizes this early and treats it as a serious medical emergency. So I, as the family member, was quite frustrated that first nurse noticed new onset neuro changes as serious as hallucinations and really didn't escalate it. She kind of blamed that on the dementia, but it was a new symptom for him. And when that night nurse came on and we saw that waxing and waning level of consciousness, that change in level of consciousness, she really took the reins, called in the team, and escalated the situation. So if you've got a client experience delirium, here's what you need to know as the nurse. First, safety. All right. We got to get that client in a room close to the nurse's station. Get the bed alarm on, lower the bed, remove any clutter they could trip on. I don't want you to jump straight to restraints. Restraints are known for worsening delirium and really should always be your last resort. But if possible, get a sitter in the room to help reorient. I ended up staying over that night and kind of acted as his sitter to keep him in bed and keep him safe, because that's going to be our number one priority as a nurse. Our second priority is all about reorienting to the environment. So we're going to turn on soft lights so it's not pitch black and shadowy. That darkness can make hallucinations worse. We want to make sure they can see the clock. And I had a calendar that was pulled up so I could continue to reorient to, where are you? You're in the hospital. What day is it? It's Tuesday. Why am I here? You have an infection in your lungs. We're going to speak slowly, present one idea at a time, and give the client plenty of time to respond. And you're likely going to have to do this over and over again. Reorientation does not happen quickly, but we need to be calm and consistent. And the third thing is we need to think about what triggered the delirium. Again, this is not a progression of dementia. He was more vulnerable to delirium because he had dementia, but that did not cause this acute electrical storm. Okay. So, in my specific case, I believe that this family member suffered delirium due to the polypharmacy, the benzodiazepine that he had gotten in the emergency department on being admitted, the opioids, the antibiotics. These were all new medications that had a dramatic impact on his mental status. Other things that you want to assess as the nurse, we want to look at vital signs. So, if their temperature is up, or for example, oxygenation has dipped, or their respers are increased, these are all things increasing metabolic demand. They can change chemistry in the brain and precipitate an episode of delirium. The provider very well might order some labs to check electrolytes, renal function, blood gases, etc. And we might need to adjust oxygen to kind of keep those saturations up and keep everything status quo while we get things under control. Now, you might be wondering, especially if you have a client who is agitated, having hallucinations, they could start to become a danger to themselves if they are trying to pull out lines, tubes, drains, ambulate, and they are a fall risk, etc. I feel very fortunate. I was able to sit with my family member and make sure that we didn't get to that point. So we didn't need to go escalating with other medications and interventions. But it certainly sometimes is the case that we need a low dose antipsychotic to help with severe agitation, hallucinations, again, especially if they are a risk to themselves, pulling out lines and etc. What you want to make sure is that you are going low and slow, using the lowest dose possible, and monitoring for side effects. Remember, the side effects of antipsychotics are those extrapyramidal symptoms, QT prolongation. And also remember, these medications aren't treating delirium. They are really just calming the storm while you fix the underlying problem. So antipsychotics that should be on your radar are haloperidol, olanzapine, risperidone. I would say, in my experience, haloperidol or Haldol is what I have seen the most. But again, it has a really hefty side effect profile. So we are not going to use it as our first line. For my family member, we could kind of keep him safe with me there at the bedside and making the environment safe. But certainly there are cases where we need a little bit of extra help. And I have often seen haloperidol used for that. So for my family member, it really took a couple of days, at least 48 hours, for things to start to improve. We had to bump his oxygen up. That got his respirations down. We were able to get his temperature down as the pneumonia started to resolve when the antibiotics kicked in. That helped, as well as those opioids and benzodiazepines getting out of his system. I personally think that made a really big difference to his mental status. And all of those things working together to kind of treat that underlying state over the next 2 days got him back to his pleasantly confused baseline, where he was totally oriented to person. He knew who I was. He was chatting about his daughter. He was not seeing anything, which is amazing. And that's another key point to drive home, is that delirium is totally reversible if we catch it early. We're not going to cure the dementia. That is chronic and progressive. That condition will stay, but the acute delirium can totally be resolved once that stressor is removed. So, with that being said, again, I really wanted you to kind of get the difference between these two conditions. I'm going to bring you back to our NCLEX question, and hopefully now you can get to the right answer and understand why. So we had an 82-year-old with moderate Alzheimer's. They're usually calm, recognize his staff, and ambulate with a walker and one-person assist. Tonight, they are disoriented, pulling at their IVs and shouting about men in my room. They're drifting between agitation and drowsiness. Which nursing assessment finding best supports delirium rather than a progression of dementia? We had A, gradual decline in short-term memory over the last 2 years. B, a fluctuating level of consciousness and an inattention during the shift. C, difficulty recalling the names of her grandchildren. Or D, progressive problems with word finding and organizing thoughts. So now remember, all of these could be going on. But which of these really pinpoints that we are dealing with that acute delirium storm versus the chronic and progressive nature of dementia? That would be B, fluctuating level of consciousness, that waxing and waning, I'm agitated and now I'm drowsy, really captures the heart of delirium. That client is dozing off mid conversation, then waking up extremely agitated. Maybe they're seeing things that aren't there. I very frequently in our test questions see that waxing and waning level of consciousness as the kind of classic presentation of delirium. It is basically telling you that that brain is not okay. The brain's arousal system, the ability to focus are being disrupted by an acute underlying problem. The other three statements are more chronic and progressive, that gradual decline in memory, difficulty recalling names, progressive problems with word finding. These are chronic and long term, which are most indicative of dementia. So that's really what I'm getting at here. Hopefully, you've already got your key takeaway. Delirium is acute. We've got fluctuating level of consciousness. Dementia, it's chronic, it's gradual, it's much more about memory and cognitive decline with a relatively stable level of consciousness. So just remember, you can have both happening together. Someone with dementia is at higher risk of delirium, but we want to focus on the chronic progressive nature of dementia and that acute onset of delirium. All right, future nurses, that is a wrap. If you found this pod helpful, I'd love to continue supporting your nursing journey through nursing school, the NCLEX, continuing ed, and beyond. Archer Nursing has you covered with on-demand video lectures, high-yield question banks, live case study reviews, and so much more. We want to help you master tough concepts and make it fun. So join us over at archerreview.com. Follow us on socials at Archer Nursing for more free nursing tips and study resources. Thanks for tuning in to Pulse Check with Archer Nursing. I'm Dr. Morgan Taylor, and I'll see you back next time.